Yeah, thank you everyone for coming along. This is the first webinar we've had in a little while, actually, for Bioream. We had a bit of a break in the program, but we've got another one coming up in a couple of months as well. So keep an eye out for that. We've got some these great couple of talks lined up. So we're really delighted this time to have Dr. Jakob Löndahl. So Jakob works at Lund University. He's a senior researcher in aerosol technology. His research is all focused around applications of aerosols and understanding the deposition of aerosols, and in particular, aerosols related to disease. So, be that in disease transmission. So, for example, the transmission of COVID-19, for example, is very active research in that area during the pandemic, and also in applications for the measurement of lung diseases. So I think it's going to talk about that a fair bit today as well. So you may be aware of the airspace dimension assessment technique, or ADA, which is a novel new method for assessing essentially the airspaces of the lung, and it's a sensitive measure of early disease. And again, I think that's going to be the subject of today's talk as well. So his title, as you can see, is Experimental Studies of Respiratory Tract Deposition of Aerosol Particles in Healthy Volunteers and Patients with Lung Disease. So I will hand over now to you, Jakob.
Thank you, and thank you for inviting me to have this talk, which will be about experimental studies of aerosol particle deposition in the lungs, and especially in patients with respiratory disease. It was nice to hear about your network in UK in the area of lungs and aerosols. It seems to be a very good one. I started with trying to measure deposition of aerosol particles in the lungs as a PhD student. It's 20 years ago now, and still do work in this area. And for me, it began with developing an experimental setup to measure deposition of ambient air pollution in the lungs. I will not go through the machine, but I built an instrument published in Journal of Aerosol Science many years ago. The basic idea was just comparison of inhaled and exhaled aerosol particle size distributions. And then I used this instrument to measure the deposition of inhaled hydrophobic spherical particles, and then diesel exhaust particles, biomass combustion particles, candle smoke particles, welding fumes, and all sorts of things that we just happened to come across. I have a physics background, and my supervisor was a physicist, so we were mostly interested in different types of aerosols. But after a number of studies, a physician asked me, a medical doctor, if I possibly could think of including some patients with respiratory disease. And well, why not? I thought, but I asked my supervisor, and he at that point said, well, it's just complicated, so why should we do that? But anyway, I did some measurements on a small group of patients with chronic obstructive pulmonary disease, COPD, for diesel exhaust particles. And why should we care about lung disease? Well, from a medical point of view, it's the patients that inhale medicine, not the healthy ones. So this is important to understand how the aerosols deposit in lungs with disease. It's also people with lung disease that are more likely to be affected by air pollution. And just to give you some numbers, you probably know similar figures or these ones, but it's a large part of the global population that suffers from lung disease. COPD, for instance, it's almost 400 million people having the disease, and it costs huge amount of money. It's I think World Health Organization estimates that it's the third leading cause of death globally. We have 260 million people suffering from asthma, and so on. So respiratory disease is really a big issue. But when it comes to aerosol particle deposition in patients with disease, it's much more complicated when studying healthy lungs. So I did a survey. This is in a review paper I wrote some years ago, where I just looked at experimental studies from the first ones in 1948 up to 2013 of respiratory tract deposition of aerosol particles, small aerosol particles, or at least the studies should include some small aerosol particles. I think I put the cutoff at around 300 nanometers. But basically this covered, I think, the majority of all the experimental studies in the area. And in total, these 40 studies that I found after some work digging in the databases included the 421 subjects. Majority was men. A large part of the studies did not include any information at all about what type of subjects or volunteers that were included. Basically, I think because many of the experimental groups were physicists, and they didn't care much about reporting information about the subjects. So in best case, there was something like age, but often much information was missing about gender or lung disease, smoking, etc. Of all these 420 subjects, 50 were reported. 50 subjects were having lung disease from 6 studies, half of them with COPD and half of them with asthma. And so this is really a gap in the experimental literature. We have very little data on aerosol particle deposition in patients with lung disease. So the study I did for diesel exhaust particles, here is the data. I looked at the deposition fraction of the diesel exhaust. It's rather small particles, so ranging from 10 nanometers up to around 500 nanometers. And these patients and healthy volunteers, they were just breathing spontaneously. And what I found was that there was a lower deposition of diesel exhaust particle. The deposition fraction of the aerosol was lower for the COPD patients. But in fact, the dose of aerosols was higher because the patients needed to breathe more heavily to get enough oxygen. And although they had a slightly lower deposition fraction, they received a higher dose of aerosols. But I was especially curious, why did the particles deposit less efficiently? And I will come back to the explanation for this. But just to begin with, I tried to compare with other experimental studies. And here is the data. There were 3 previous studies with particles in this size range. And you can see the blue ones, the blue dots and the blue line, it's the healthy group. The red line, sorry, I mixed it up for my own study. So this blue line should be red. It was lower for COPD patients, but it's correct for the dots. But as you can see, the former studies didn't really agree. Some found the higher deposition in the patients, some found the lower, and this was difficult to explain. So if we look at specifically these individual studies, for instance, there was a very nice one by Winfried Möller and a group from Germany, where they looked at aerosol particles marked with technetium, or a radioactive tracer. And in the healthy lung, you can see that the aerosol particles is depositing globally in the whole lung. But in patients with COPD, it seems a bit more patchy. Especially, and for a shallow bolus of aerosols, the less deep inhalation, more particles are deposited centrally, while it's much more heterogeneous and patchy in the lungs with disease. This study did, however, find a higher deposition of aerosol particles in the COPD group. Looking into another German study from the beginning of the 90s, they also found a higher deposition of the aerosols, contrary to what I found. But when you look a bit more carefully into the data, in this study, the groups were following a controlled deposition breathing pattern. So all subjects should inhale according to a very well specified breathing maneuver, inhaling 1 second, exhaling 1 second, waiting, and so on. The normal patients, the healthy ones, or the normal, not patients, the normal group, they were able to follow this breathing pattern. But those, it's not the old ones, it's those with the obstructive lung disease. They were not able to exhale as quickly as the other ones. So they had a slower breathing, especially a slower exhalation, which is not surprising. This is what happens with COPD. But that also means that the aerosol particles stayed for a longer time in the lungs, and this increases the deposition. So it's not clear from this study what the results would have been if they all have the same breathing pattern. Another study by James Brown in US, they had 3 patients with emphysema, that's one component of COPD, some with obstructive lung disease, and the healthy group, the white ones. And there seem to be differences, especially for the obstructive patients, with a higher deposition with when there is a lower forced respiratory volume, when a lower value on this line means more severe disease. But it's really too few patients to draw any conclusions. You can't do much statistics on this. So on the whole, I found based on these 4 studies with experimental data, it's rather unclear how lung disease changes deposition. Something is happening, but it seems to depend on a lot of different factors. Changes in the lungs, different breathing patterns, obstructive lungs where the airways may be damaged, or changes to the alveoli. So I have been digging deeper into this for the past 10 years. So what happens if we just look specifically at this disease, COPD? There are 2 things happening. One is that conducting airways will change. If there is airway obstruction, there will be inflammation and swelling of the airways, and the airways become more narrow. This is likely to affect deposition and airflows, maybe cause local regions with turbulence or changes in how the air is distributed within the lung. Another change is emphysema, which is basically breakdown of lung tissue. And emphysema means that the alveolar walls may be damaged, and instead of small alveoli, there becomes larger air spaces. And this is, of course, also likely to affect deposition. If an aerosol particle reach a larger airspace, I would assume that it deposits less efficiently, because there will be a longer distance to some surface where it can deposit. So we have these 2 different things that may affect the deposition. And patients typically have different degrees. Some have more emphysema and some have more obstruction. Can look at the lung tissue. This is just from histology. It's a normal lung with small alveoli, and this is a lung from a smoker where you can see emphysema, large areas where the alveolar walls are destroyed. I was thinking that maybe this emphysema could explain the lower deposition of small particles, which I found. Bronchitis, that's one thing, but most of when it comes to particles in the nano size range that deposit by diffusion, most deposit in the alveolar part of the lung. And in a normal lung, most of the particles may reach some surface, but if there is emphysema, less particles will deposit. This was the hypothesis. So we constructed a new instrument specifically to measure deposition in a more controlled way, just at this very well-specified depth in the lung, and also with a well-specified breath hold time to be able to sort out the different components in deposition. This is the breathing pattern we used. It's copied from diffusion capacity measurements in healthcare, where they measure with carbon monoxide. So a short period of normal breathing where without aerosols, so particle-free air, then exhaling, emptying the lung completely, inhaling one breath of aerosol, specified breath hold time, which is timed also by the computer, and then exhalation. And to do this, I just focused on one particle size, 50 nanometer. Measure the inhaled concentration and the exhaled concentration. And well, from the first study, we had 17 healthy persons, some asymptomatic smokers, and some patients with COPD. At two different, or at least I'm just showing here, two different lung volumes. So deposition at 1,300 milliliters down in the lung, and deposition a bit deeper. And in both cases, it seemed that the COPD patients did have a lower deposition of nanoparticles, presumably due to emphysema. We then was thinking, could we divide these components of deposition? So we found that by changing the breath hold time, the deposition was changing. And here it's the other way around. We have particle recovery. The recovery is the amount of particles that is exhaled, rather than the particles that are deposited. And the amount of particles that is exhaled, it decreases with increasing breath hold time. Not surprising, because it's more time for deposition. And this followed a nice line on a log scale. And with a bit of mathematics, which you can read about in the paper, the half-life time, I assumed it was directly related to the radius of the alveoli. And well, this so a line it's basically described by two numbers: the slope of the line and the beginning, the starting point, R0. And by looking at the slope, we made an equation to calculate alveolar dimension. This was a hypothesis that there was a direct relationship between the slope of this line and the particle recovery and the size of the alveoli. We tested this for some healthy people, and found a number of things. But for instance, we found that when you exhale about 1 liter of air and pass a dead space in the lung with conducting airways, the alveolar size, according to this equation, was similar, going irrespective of how deep we measured, which at least confirmed that we measured something reasonable. We also found alveolar dimensions that were reasonably within sort of histology. But we had no way to really verify that we measured something which was real. So we had the question: could the aerosol airborne nanoparticles be used to measure something in the deep lung? And well, here is a list of all the publications we made on this. But we contacted Jim Weil in Sheffield, who has or his group has a very nice machine to measure things in the lungs by MRI with hyperpolarized gas, and by their method they could get a number of some sort of mean linear inset or diffusion distances in the lungs, something that was related to the alveolar size. So we had a group of around let's see here. So we had 24 healthy subjects that we measured with our method, which we now called airspace dimension assessment with aerosols in Sweden. And then we made the 2 journeys to Sheffield and measured with the MRI and compared if the diameters we got from our aerosol measurements had some relationship with the diameters measured with the MRI method. And quite interestingly, there was a very good correlation between these 2 methods. The average airspace radius measured by MRI was 281 micrometer for this group, and the radius we got was 279 micrometers. Maybe a bit of luck, I don't know, but at least we were measured the same distance. And also we found a relationship between the 2 methods. So as you can see here, there was quite good correlation coefficient and also a very high likelihood of significance for the correlation. So with those with a smaller alveolar dimensions measured with the aerosol method also had smaller alveolar dimensions measured with the MRI method. And we could see in this study also that the alveoli increased with age, which is expected, although everyone was healthy. So now we had a method to try to figure out things with more precision, also for deposition, also for healthy ones. Could this be used for lung disease? And to begin with, we began with the largest study. It was just by chance. There was a big cohort study in Sweden. It was called SCAPIS, the Swedish cardiopulmonary imaging study, and we used our instrument to measure on about 700 people that attended this study, and they did all sorts of lung function measurements. These were not really patients; they were just the population average. But some of them were smokers. It was not 420 smokers. I must have some number wrong here. But this 47 of them were patients with emphysema. They were not actually patients. They had emphysema was detected in a CT that was made during this cohort study. So early emphysema, which were they didn't know about before coming. The dimensions of the alveoli that we measured with the aerosol particles was, well, most were normal, but some had larger airspace radius. And it turned out that the group with emphysema, although it was early disease, they had larger airspaces or less deposition measured with our method. So maybe we could use aerosol particle deposition actually to detect something in the lung. And then we continued. We looked at different types of COPD. And here we found one patient group which had just emphysema without obstruction of the airways. It's patients with alpha-1 antitrypsin deficiency. Those with alpha-1 antitrypsin deficiency often have a breakdown of lung tissue, but it's no damages to conducting aspaces before it becomes rather severe. And we had smokers, which have a bit of both, and healthy subjects. In this study, we had 25 healthy, 23 smokers, and 18 with alpha-1 antitrypsin deficiency. And we compare these groups. I think the figure to the left is less important, but in the figure to the right, we could see that the radius, which was related to the aerosol deposition, for the healthy group, it was within a small interval, 270 micrometer. But it was much larger for both the emphysema group, although this was quite early emphysema, and definitely for the smokers. We also, if we look at the left figure here with the R0, which we think is related to the deposition in conducting airways during the flowing part of the inhalation. It was similar to those with alpha-1 antitrypsin deficiency, the emphysema group and the healthy ones. Both these groups had normal conducting airways, but the smokers had a different deposition, a different R0, which the interpretation of this is that these two components of COPD is affecting the aerosol deposition in two different ways. We have enlarged air spaces, which decreases the deposition or increases the amount of exhaled particles. And we have airway obstruction, which seems to increase the deposition. And to see this, it's really necessary to control both the breath hold time or the time in the lungs, and also the airflows to divide it, which was not really done in the previous studies on aerosols. That lung disease really alters the deposition of inhaled aerosol particles. And this is critical, I think, to look deeper into, because it affects the dose of medicine for inhalers, and it affects how much air pollution people are exposed to. The deposition of aerosols may both increase and decrease depending on type of disease in the lungs. So it's not easy, and we have to really look at the diseases separately, which is much more complicated than just looking at healthy, because and deposition is also much more heterogeneous for patients with lung disease. This difference in deposition, I think we've shown that for nanoparticles, it can be used for detection of lung disease, as in the AIDA method, which we are developing. And when it comes to the AIDA method, we have now measured on more than 1,000 people. It seems to correlate strongly with MRI, with hyperpolarized gas. There is a weak correlation with normal lung function, which I think is nice, because we measure something which is really not really captured by other diagnostic methods, which are already available at the hospital. It is difficult to measure things in the deep lung. And it's a fast and simple and precise method that may be used to detect and diagnose disease in the lungs, which would otherwise not be detected.
Jakob has requested we just add this slide in at the end that he didn't get a chance to show, acknowledging his funders and collaborators that contributed to the work. Thank you very much for watching.